Hey everyone, welcome to our live session. We're going to discuss what's happening in reimbursement for your medical practice. For those that don't know, I'm Theo Harvey at The Real Theo Harvey on YouTube and other channels. But love to kind of talk to you about doing these more often, these live sessions where we'll do lunch and learns and other things to kind of educate you on what's happening in healthcare right now and what's going to be the new normal. So we're going to get right way straight into it. So if you have any comments or questions, we'll be kind of monitoring everything and so that you can get a sense of what's happening. And please ask away as I kind of go through this session today. So thank you for your time. I know your time is extremely valuable. So don't take it lightly that you had time to spend with us a few minutes. So let's get into it. So today we're going to talk a little bit about the remote care reimbursement changes for 2024. So the physician fee schedule recently came out for those that don't know, and this is something that happens every year. This is something that affects every healthcare practitioner out there, and there's a lot of changes that happen. For this specific lunch and learn, we'll talk a little bit about the specific changes around remote care. So we'll talk about that in a second. So again, the goal today is to discuss the proposals released by the Centers for Medicare and Medicaid Services, and they released them this summer in July to kind of give you a sense of that. Typically gives everyone time. It's about 6 months because in December the final rule comes out to make recommendations, questions, send out proposals. So we'll talk about that process as well. But the focus today will be on kind of remote care programs like remote patient monitoring, chronic care management, to kind of give you a sense of what's changing, what's not, and what some of the bad things are happening, according to the physician fee schedule. And then we'll also discuss some new CPT codes that are going to, you can definitely take advantage of, right? That can help your medical practice grow this year. So of note, a little housekeeping, please, everything we say here, these are all proposals. They're subject to change, but check with your legal and billing teams, to verify everything we're saying here. This is directly from the Federal Register where they release the physician fee schedule. It's over 1,000 pages, but, our team went through pretty thoroughly. Also, these proposals can and probably will change when the final rules announced in December to take effect January 1st. So be prepared for that. And again, the comment period is still open. You have actually until Monday. So you have the weekend to go through that and make your comments. And you can make your comments there in the section, the cms.gov Medicare payment fee schedules physician link there below. So definitely you still have opportunities there to kind of make comments and talk to CMS or what your thoughts are about their proposals. So let's get into it. All right. So the bad. Reimbursement changes. So you probably saw this if you're in the Medicare space, if you're not just Medicare, but just practitioner and healthcare in general, reimbursements will change. So CMS will be cutting reimbursement. They released its annual proposed changes to the physician fee schedule, which includes roughly about 3% change in what they call the conversion factor. This will be decrease of 3.34% from 2023. So this is definitely something that's alarming to a lot of healthcare practitioners out there because with rising inflation, wage growth, with mid levels and other healthcare staffing, costs going up. This will be a problem, especially if relying on thin margins for your clinic or your healthcare practice. And so this is something everybody's kind of pushing back on. But remember, they kind of didn't decrease reimbursement last couple of years because of the pandemic. But also, this is a long trend of CMS starting to cut more and more reimbursements in fee for pay, because this is the long-term trend what they're going. The last 10 years, I think it's been 22% reduction in reimbursement for fee for service. So we'll talk about why that is. But let's do a refresher. Conversion factor. So what is that exactly? So let's talk a little bit about how medical billing works. As a refresher, I'm sure a lot of you may be familiar, but your payment is tied into this crazy equation. There's even more that goes into it that's based on geographic location. But just to keep it simple, it's based on what they call these RVUs, relative value units. One is based on your work, one is based on your practice, and one is based on medical malpractice insurance. So all that, if you remember your algebra, is addition, but really the one that's going to affect it the most is the multiplication, the X, the ones outside of the parentheses, and that's the conversion factor. So anytime that conversion factor changes, that is going to be a detriment to what's going to happen to your payment. Yes, the work RVU, PE RVU, and MP RVU, those are relatively static year to year. They can change based on different procedures or different malpractice, but typically they kind of stay pretty static. Well, that conversion factor is the one where CMS will change from time to time and can affect your payment for any service that you do ongoing. So let's talk about work RVU just real quick. So basically, it's just a scale to kind of determine what kind of work you do, what work is more valuable and will take more time. Obviously, work that takes more time, you will get paid more for it. So for example, removing a foreign body from an eye, which is a code 65205, it's going to be assigned about 0.49 work RVU. But if you're going to perform a minor eye wound repair, 65270, this is going to be valued at 1.95. So in essence, CMS is giving you more money because they know it's going to take more time, more effort, more expertise to kind of handle that more advanced type of procedure. So they're going to roughly pay 4 times the work. They'll pay you 4 times what it's worth to help with that foreign body removal. So that's what the work RVU. So it just gives a sense of a level playing field to know that whatever time you're going to use to help the patient, you will be compensated accordingly. The next one is the practice expense. So this is components related to addressing the cost of maintaining practice. So rent, equipment, supplies. They typically tag it to a lagging indicator, like what happened last couple of years. Unfortunately, sometimes the inflationary things that we're facing now, where costs are rising, they're not kind of putting that into the equation. So that could affect a little bit of why you're not seeing changes to that. And then finally, malpractice. So typically, every practitioner needs to have malpractice insurance, and so they give you a little bit off of every procedure to make sure you can kind of pay for your malpractice insurance, and that's pretty static for several years. So that's kind of what goes into it to kind of get a sense of like what's going to change. So again, the conversion factor will impact your payment the most, and that's what's happening now with the reimbursement. That conversion factor is changing, so you're going to see roughly about 3% cut in your reimbursement for next year. So that's the bad. So let's get into the good. So CMS is aware of this. One of the reasons why they're cutting some of the payments in this fee for service is because they want to move everything over to value-based care programs and new type of procedures that are going to be relying on continuum of care, right? Making sure patients stay healthy over time. And so that's what the good is. These new codes are coming out. So one is what we call the Caregiver Training Services, or CTS. So CMS finally has acknowledged that caregivers play a crucial part in helping patients care. This is 180 flip to what they've said before. So as we all know, patients rely on their loved ones, their friends, their neighbors to help them, especially for those that suffer from those really tough disease states and conditions. And so CMS has acknowledged that and wants to help in that process. So how are they going to do that? Well, so for patients who suffer from any of these following conditions, like a stroke or dementia or anyone on the spectrum, they're going to be able to help them by making sure there's a caregiver, like a family member, a neighbor, or guardian, that can be trained by the treating practitioner. So in other words, the practitioner will be the one that's going to be able to provide training to the caregiver to help them help the patient with these type of disease states. And so there's these different codes that, without getting into too many details, but high level, one is around is making sure the caregiver understands behavior type management programs. So training the practitioners using their time to train this caregiver to do things that will help patients from a behavior standpoint. The other one is around caregiver training services based on a therapy plan. So there's a plan that the practitioners can come up with. Educating, taking the time out of their busy schedule to train the caregiver on that is going to be crucial. And that's something that CMS is really looking at helping. And both of those have, in addition to the 60 minutes and 30 minutes, they have add-ons that can be added on for additional time for the physician to train those practitioners. And then finally, there's going to be a code around group training up to 5 beneficiaries. So basically, if you have a caregiver that's managing that's helping with multiple patients, or caregivers that can be in a group room, you'll be able to kind of train them. And so again, these are proposals. They could change the intricacies and how they're going to work. Will be more detailed in December. So we'll probably do an update then to give you a sense of what the final rule says. And so you get a better sense of how you can prepare in January for these new codes. Next, community health integration. So this is in line with understanding, patients need more help, right? And so this is really about leveraging social workers, right? So this is a code to help social workers or community health workers who can kind of help with things that go beyond just chronic care management, right? So the unique thing about this code is that this will be an add-on to what you're kind of already doing with maybe remote patient monitoring, RPM, or CCM, chronic care management. So this community health integration piece will be helping with things like social determinants of health, taking time to understand a patient's personal history, customizing health education to fit a patient's context, thinking about multilingual support, things like that. Really strengthen a patient's ability to advocate for their health needs, walking through the path of talking to the hospital about the needs of the patient. All these things, are those added kind of social work components that CMS realizes is so important for the lifestyle, the health, and the helping the patients through their programs long term. So this is something that we'll see more of, but this is really helpful, especially for those of you who've implemented some kind of social work services with your patients, because it's just extremely valuable, right? We see it as well in our company, where how we work with our patients. Yes, we're using chronic care management, but there's a lot of social worker components that we go into, kind of making sure these patients have everything they need. And so I'm glad CMS is looking at that. So in terms of reimbursement, it'll be similar to CCM, CPT codes, if you've seen those. So like I said, this is approximate average based on, some crosswalks and things that our team has looked at. But like I said, once the final rule comes out, we'll be able to know more exactly what the reimbursement will look like. And again, CHI, community health integration, can be billed in addition to CCM and RPM. So the difference, I would say, chronic care management is more around the patients, managing their disease state 2 or more, which would be hypertension or diabetes, anything related around that, medication compliance, understanding how to stay healthy, all that to manage that condition. CHI will come into play, community health integration, when that patient may need to understand more about how to get education around managing that process, or how to navigate if they go to the hospital, if they have a relapse or exacerbation. The CHI component can play in there to kind of help that patient navigate that ED visit. So that's kind of the delineation so far. But again, December, we should know more. And then last but not least, principal illness in navigation. And this is related to serious illnesses like cancer, very similar to CHI, but is really going to be work on how to kind of have a clear plan of the patient as they're kind of going through this diagnosis, around giving advice, encouragement. One thing that was interesting is looking at I think they have patient support groups, right? How does that play into PIN and helping patients navigate this new disease state? And is that something that could be compensated? And so that's still kind of, being worked out and looked at. And again, very similar to the 99490 and 49439 codes, CCM, and doctors can, charge for, PIM along CCM and RPM. So that's the good. So like I said, they are trying to help providing more resources for your patient population so they can stay healthier. And so those physicians, practitioners, nurse practitioners, others who get involved in this process and take advantage of it, they will see an outsized growth and opportunities. So fine, the same, RPM, RTM, RPM, remote patient monitoring, RTM, remote therapeutic monitoring. So unfortunately, there were no changes for remote patient monitoring, but CMS reestablished that the patient must be an established patient of the practitioner. So during the public health emergency, physicians could see patients that they never saw in the last 12 months or weren't an established patient. That's gone away as of May when the PHE ended. So now these patients have to have been an established patient of the practitioner in order to kind of enable these programs. Also, they emphasize that patients must get to 16 days or more readings a month to qualify for CPT 99454. There was some discrepancies, some misunderstanding around, like, could they only need 2 days? Is it just, one day? Is it like, can they do multiple in a day? No, has to be 16 distinct days in a calendar month at this time, right? But so wherever vendors you work with, if you're looking at RPM services, make sure they have programs, processes in place to understand how to make sure your patients get those 16 days if you want to bill for 99454, right? That's not a requirement if you're billing for the other codes like 99453 or 99457 and 8. But that's definitely something that you want to make sure that you have a plan of action on how those patients get those 16 days in a 30-day calendar period. Again, only one practitioner can bill. So, right, you can have multiple ones billing for RPM. Only one can do it. And then also the multiple devices per patient, they really only fall into one code. So a patient can have 5 different devices, but you can only bill for one 99454. And the reason why CMS kind of reiterate this, they said they have received many questions and parties and billing scenarios, and they felt it was just they need to clarify and be appropriate use of these codes in general, because it's important to share what's really happened. So we have a restatement of what's clear and what's not. And so I think it's really clear that I'm glad that they kind of reiterate that. So all vendors, all practitioners, all doctors know exactly what's going to happen and what's going to be successful to make an RPM successful for 2024. Finally, remote therapeutic monitoring. For those that don't know, this is a new code that got released this year, and it was supposed to be game changer in terms of making sure patients stay compliant to therapies that were recommended to them. The initial rollout was for respiratory, so patients, for instance, on inhalers, or musculoskeletal, so basically patients going through physical therapy. Later on, they announced cognitive behavior therapy, so patients are doing some of that with app-based solutions that they're tracking, making sure they do that, then that was something that could be reimbursable. But unfortunately, at this time, no other therapies or other conditions were kind of looked at for reimbursement. So, for instance, if a patient is, taking, you're looking at a patient who has hypertension, and you want to make sure they're taking their medication, medication compliance with blood pressure medications. Unfortunately, at this time, that will not be reimbursable. So basically, a pulmonologist, physical therapists, behavioral health therapists, those are probably the top three that probably be take advantage of RTM. And still early days. I think CMS is still looking for my data to understand exactly how this is going to work out for them. So more to come. But like I said, this is unfortunately the same right now as of now. December, we should know more, and we'll definitely update you on that as well. So again, if you are struggling on how to implement, these value-based care strategies for 2024, we just want to take this time to just say, hey, look, we can help. Want to talk a little bit about my company, SensorMed. So we offer a full suite of programs and software to help you navigate this new normal in healthcare. We have guides to training and coaching programs, to software, to services to kind of get you up to speed to hundreds of patients pretty rapidly, so you can take advantage of these programs now and make sure you see the added revenue that you're losing from some of the fee-for-service revenue that they're taking away. And again, by 2030, CMS will be starting to, looking at moving all Medicare Advantage patients into these kind of value-based programs. So let's get a head start. This is a good time to do it. So again, if we can help in any capacity to get you along this path, definitely please reach out to us. You can schedule time with us at the following link, SensorMed Practice Value Creator, and we can kind of walk you through, our processes, and so you can get a better sense of, how things can work for you long term. So at the end of the day, our goal is to make sure that you're being do the best you can with your patients, and making sure you can have the best success for all the things that you're doing with your patients. So again, our hope here is to make sure you get the best training and learning over time around these new programs. So be on the lookout for more lives in the future. Also, we do monthly webinars to give you up to date and the latest and greatest. So again, if you have any questions, please let us know, reach out to us, but we'd love to kind of hear from you. Once again, I'm Theo Harvey. Thank you for your time, and we look forward to working with you in this new normal of healthcare.